great to see such a big crowd for here tonight to talk about hip and knee arthritis and joint replacement. So I'll introduce myself. I'm Wayne Machete. I'm one of the orthopedic surgeons who operates at mostly Hitchcock, but sometimes here at APD. We have a great panel with us who are going to talk about multiple topics here. So first to my right here is Dr. Peter Schilling. He's going to give a general overview of arthritis. Dr. Lozier's on the end, Peter Lozier. He's going to talk about non-operative treatments for arthritis. Becca is one of our physical therapists who works out of the Heater Road office and also actually helps me in clinic. She's going to talk about doing physical therapy and the importance of musculoskeletal strength. And then we have Dr. Tomic here, who's an orthopedic surgeon here at Alice Peck Day, who focuses on hip replacement, and he'll give a brief overview of total hip replacement. And then Dr. Oram down on the end will give us a brief talk about total knee replacement. So we've got a lot of content. We're going to try to get through it as quickly as we can. We're going to wait to the end for questions. I imagine a lot of you may have questions. I think it'll be easier for the flow of things if you can write your questions down. Hope is handing out some paper and pens. And so if you have questions, please write them down, and then we'll try to address them all at the end. Lastly, I should mention we have Emma here as well, who's probably the most important person on this panel. She's a satisfied customer. So she's actually had a hip replacement by Dr. Tomic and is clearly doing very well because he invited her. So, and so we will also have the opportunity if you want to ask Emma questions about what it's like to go through hip replacement.
We're going to kind of get through this, hit the high points, because I think the treatments and what to expect are probably more what you're interested in. So, general overview of arthritis. I don't know if this picture resonates with you, but it's a painful condition, and it affects a lot of folks. Mainly when we're talking about arthritis, there's a bunch of different kinds. We're talking about osteoarthritis, and I'll explain a little bit more about that. And that's the wear and tear kind of arthritis. You got hip and knee experts here, but know that it can affect any joint, really. But the hip and the knee being very common and very debilitating, too. So you're not alone in this. And the full room kind of, explains this pretty clearly. But this is just the number of people who report that they've got problems with joint pain and arthritis. And this is folks over the age of 18, right? And I realize most of the room here, you're around 35, 45, sort of that range. You can see it's a huge segment. And when you group that with low back pain, which I'm sure no one has in conjunction with their other joint pain, it's a huge share of people. So you're not alone in this. It's a big problem, and it really affects people in profound ways. This is numbers of days missed from work just by virtue of joint pain or back and neck pain. If you group those together, that's over half of the days missed by adults over the age of 18. So again, it has a profound impact. They say almost 3/4 of folks in North America, Canada, and apparently Mexico combined over the age of 65 are affected by this condition to one extent or another. It's easy for me to try to jump in and steal the show on hip and knee replacements, but I'm not going to. What you'll need to look at in this graph is it's kind of a hockey stick. This is number of hip replacements done. This is a little bit dated, actually, 91 to 2004. Seems like yesterday, but 20 years ago. And it's a hockey stick. It's going up to, as of 2003, it was like 250,000 a year. Well, it's the same with the projections. It's an ongoing hockey stick. 2030, the projection is well over 500,000. And the same goes for when surgeries have to be revisited. When we're doing them on younger folks, then of course we've got to sometimes revisit it, but those are increasing share as well, and that's the red line. There are a lot of different causes of joint pain. I think it's important to acknowledge that. One of the, I think, big masquerading causes of joint pain that to be aware of when it comes to the knee and the hip is sometimes it can be caused by the back. I'll kind of leave it at that just to know that not every joint pain is necessarily osteoarthritis of the knee or the hip. There's the hip joint. Probably didn't need the doctor to tell you that, but that's where it's located. If you'll notice the location, it's actually the joint itself is more located within the groin. So folks with a hip problem, oftentimes the most common presenting factor is pain within the groin, sometimes within the buttock. The hip joint itself is in some ways kind of a simple joint in terms of it being a ball within a socket. So in the pelvis, you've got the socket side. The ball fits within that. You'll see on some of the nice implants that the other surgeons have brought that it really is a replacement of that. The knee here, Some folks call it a hinge joint. It's really not. It's actually quite a bit more complicated. There's a pivoting motion that goes along with the hinge. What you'll see about both these joints, there's something called, at least within certain circles, white gold. And I don't mean a ring. What I mean is the surface coating the joint on the end of the bone. That's cartilage. That is really valuable stuff because that is one of the things that can wear away over time, and oftentimes that's the main thing we talk about with osteoarthritis is the cartilage wearing away. And that's the padding in the joint. And when the padding wears out, it sets off this cascade of inflammation that becomes painful. The other important structures to note here are these kind of horseshoe-like things. I should have brought a laser pointer, but that's the meniscus. You maybe have had a torn meniscus. In essence, what that is a shock absorber in the knee. It's made of a cartilage-like substance. When it tears, the knee is subjected to a bunch of stresses it doesn't like. It's like driving around in your car with no shocks. Is the car going to wear out faster? Yeah, it probably will. So that's what the meniscus is. Joint pain, we'll kind of go through this a little more quickly. Again, the awareness that even in healthy folks, joints can hurt for periods of time. When it starts lasting, months and months, well, that's a different story, and that's a time to get it checked out. Anyone through the aging process experiences wear and tear of the joint, whether that goes on to develop full-blown osteoarthritis. It certainly increases as someone ages, the risk of that. Not everyone does, but the risk increases. What can predispose you to it? Weight can. It's more load on the joints. Lifestyle, injury, and also genetics play a role. Maybe it's something that you've seen run in your family. I think another key point to realize too is that joint pain from arthritis tends to wax and wane. The idea that it's just a even keel toothache type pain is not accurate. It tends to be something that undulates over time. Good days, bad days. Good weeks, bad weeks. Good months, bad months. Arthritis affects the entire joint. The notion that it is just the slippery surface called cartilage is not accurate. It affects the ligaments, this meniscus, this shock absorber within the knee, even muscles around the joint, causes joint swelling. And in essence, when we get to joint replacement, what you're dealing with is end organ failure. It's when a joint is so nicked up and worn out that you've got to just fully replace the surfaces of the knee or the hip, as it may be. Osteoarthritis, osteo means bone, arthro means joint, itis means inflammation. Not complicated. Again, the symptoms, we won't belabor this, pain, swelling, stiffness, decreased range of motion. And with all this comes disability in terms of just whether that's not being able to work as effectively as you wanted to, not being able to enjoy life, your life beginning to kind of narrow down so that maybe you're bowing out of activities that previously you liked to do. Maybe it's simple things like even just being able to go up and down the stairs, put on shoes and socks. These are common things that we ask about when we're assessing someone for joint replacement. This right here on the one side is an actual picture within a knee joint. You can see it's pristine, smooth, white cartilage. It's glorious, smoothly paved road. On the other side, that's a joint that is experiencing osteoarthritis. What it actually looks like when you put a scope within the knee is this. You see areas where the cartilage is actually completely gone. There's little fibrillations and tears within the meniscus as well as the cartilage. There's a lot of different kinds of arthritis. The most common being the wear and tear arthritis, although there's a smaller subset of inflammatory arthritis, which I won't go into today as much, but that is modulated by the immune system. It's actually the immune system attacking the lining of the joint, causing joint pain. But even beyond that, there's other types of arthritis. Rheumatoid being a type of inflammatory arthritis, psoriatic arthritis, maybe even heard of avascular necrosis, which is where the blood supply to a portion of the bone around the joint is no longer as robust, and as a result, the joint becomes painful. Stages of the wear and tear. In the early stages, the cartilage itself just softens. The mechanical properties of it aren't what they used to be, and people can experience pain from that. As it progresses, you start getting larger defects in the cartilage. You might get tears in the meniscus, this being kind of part of the whole disease process. Tears in the meniscus, not necessarily a separate thing. It's part of the joint wearing out. There might even be parts of the cartilage that fleck off into the joint and cause mechanical symptoms, locking, catching. And then as it becomes severe, you actually start to see perhaps some deformity. Maybe you've noticed, you look in the mirror and you're like, I'm more bow-legged than I used to be. That can happen as a knee joint wears out, or maybe more knock-kneed. We're getting to the end here to talk about the good stuff, the treatments, what everyone came for. This is an X-ray of the hip, and we rely a lot on X-rays for diagnosis. MRIs, sometimes we use them, but honestly, the X-ray is our bread and butter. Here's a picture of someone's hips in 2004, and then looking 10 years ahead. A joint is degenerated. What you're going to be looking at in the hip is the amount of space between the ball and the socket. You can see on that image from 2015, it's pretty much bone on bone. That is osteoarthritis. In the knee, similar concept. So as you move from the image on that side to this on the audience's right, you get this same loss of joint space and loss of padding in the joint. All right. I'm going to hand it over to Dr. Lozier.
How many of you have had a joint replacement in the room? How many of you have?
Speak up.
Sorry. How many of you are considering a joint replacement or think you may have one in your future? How many of you does that give any sense of apprehension or anxiety? So I'm going to talk to you briefly because I know you're here to hear about joint replacement, but there are alternatives. I will tell you that I'm also a satisfied customer, however, of Dr. Tomac, having had both my hips replaced, running away from him for close to a decade and finally succumbing, and very happy that I did. Oops. Anybody know who this is?
Yes.
Who is that?
It's the F1 champion.
That's right. This is Max Verstappen, three-time world champion, probably going to win a fourth this year, the greatest F1 driver in the world. Why do I have Max up here? Because when somebody asks me what osteoarthritis is, I say, think of your knee or your hip as a tire. And the articular cartilage is the tread on the tire. And osteoarthritis is the wearing away of the tread on that tire. So we're going to sort of keep that car analogy through this talk. When you come to see me, we're going to do a number of things. We're going to start with x-rays. We're going to take a history, a physical. We're going to do an ultrasound to look inside your knee. We're going to discuss what we find, and we're going to make a plan moving forward. First thing we're going to do is we're going to sit and talk. And this is really my favorite part because I get to know you and learn a little bit about you. I want to know about your past. What have you been up to? And the reason we've got a motocross here is I've got several patients who are former motocross drivers. I remember the first time I asked somebody, looked like a very mild-mannered guy, maybe an accountant, and turns out he had been a motocross driver for 40 years. When I looked at his medical history, he had broken just about every bone in his body. I had a 78-year-old lady who came in. I said, what do you want to do? Sorry. I had a 78-year-old lady who came in. I said, what would you like to do moving forward? She said, I want to be able to ski. I want to be able to hike. Oh, and I jump out of airplanes. So I want to know things like that. I want to know about your past injuries. I want to know what you've done in the past, what you want to do moving forward. I want to know about past surgeries and things like that. Then we're going to examine you. We're going to watch you, if you're able, we're going to watch you walk. We're going to watch, might have you step up on a step. We might have you do a little bit of twisting and moving in various ways, see what you're capable of. If your alignment is something like this, it really tells me something about what might be going on in your knees. Then we're going to ultrasound you. We're going to look inside your knee. I can guarantee you that if we looked at your hips and your knees, everyone in this room would have arthritis at some level. Nobody lives to be 50, 60, 70, 80 years and has not worn any of the tread off of those tires. And when they take an x-ray, they're going to say you have arthritis. Yes, and that may well be why your joint is hurting, but it may not. There's other things that can cause pain. With the ultrasound, we can look at your tendon, we can look at your ligaments, we can look at your meniscus, we can see if there's swelling. It's not uncommon to find a cyst that nobody knew about that is causing 75% of your pain. And if we stick a needle in that and drain it, suddenly you walk out and you're relatively pain-free and good for another 5 or 10 years. So the ultrasound's an extremely valuable tool that I use almost all the time when I see somebody for the first time for a joint problem. Okay, so we've x-rayed you, we've examined you, we've taken your history, we've ultrasounded you. Now we're going to have a chat. This is not depicting Adam and Eve. This was supposed to describe low-hanging fruit. We're going to talk to you about getting healthier. We're going to talk about your diet. We're going to talk about your exercise program. We're going to talk about your sleep. We're going to see if we can find ways to maybe reduce inflammation in your system to make things not hurt so much. We're going to look and see if we can help you get stronger. Even if you work out every day, you might not be doing the right things. You might have some muscles that are strong, others that are weak, and that can contribute to joint pain. So we're going to try to find that right dynamic balance and that right activity profile for you. It's not uncommon. Somebody's doing most of the right things, but boy, once a week, they got to play that game of singles tennis or go play pickleball with their grandchildren. And that's the thing that's hurting them. And if we can just sort of get a few things out of their weekly schedule, suddenly their joint pain is improved a lot. You only have to do the wrong thing once in a while, and you can have a lot of pain. So we're going to look at that. We might need to help you get lighter. It doesn't look like anybody in this room needs this, but I do have patients that benefit greatly from losing a few pounds. And it's amazing. Sometimes a 5, 10, or 20-pound weight loss can literally take your pain away. We might look at taping, bracing, and orthotics to help to improve your alignment, improve the way weight is distributed across your body. It can make a big difference. We may talk about supplements. You may have questions about supplements. I may try to talk you out of taking the supplements you're taking and tell you you're wasting your money and your time. But maybe there's some supplements that could be helpful. We're going to talk about prescription medications, which can be helpful, but we want to make sure you're not taking too much or taking the wrong thing. And then we're going to talk about injections, because there are some injections that can be quite helpful. Cortisone can be a helpful thing in the short term, but can be detrimental in the long term. There are alternatives. In my office, we use a lot of something called high hyaluronic acid. We call it the Jiffy Lube for the knee. Also works in the hip, shoulder, and the ankle. And it doesn't take away the arthritis, but it can make it feel a lot better and make your joint last longer. There's a newer injection we use called platelet-rich plasma, which we're using more and more of, where we take your own blood from your body and inject your platelets into an inflamed joint. And increasingly, evidence is showing that's the best injectable option. Both takes away pain and makes the joint last longer. And we've had very good success with that. When compared, the PRP consistently over the last 2 years is winning in head-to-head studies. There's a lot of very exciting stuff coming down the pike. There are people doing stem cells of various kinds and all kinds of other injections into the knee. There's incredible claims you can find in the lay press, on the internet, and in the literature. We're keeping a very close eye on that, and when something seems truly ready for prime time, it's safe, it makes sense, and it works, we'll offer it. But so far, we have not moved into the stem cell world yet because it doesn't really show that much incremental benefit over PRP, in my opinion, to warrant moving there. So Max and his partner Sergio like to say, good tread on your tires won't win you the World Cup, but if you don't have good tread on your tires, you won't be in the race. Thank you.
Anybody been to PT before? Anybody love it? Okay. Right. So arthritis and PT kind of go hand in hand. Sorry. Can you hear me? It says now that's what I call a bum knee. Okay. All right. So PT and arthritis kind of go hand in hand. This is kind of what I'm going to go over. What do PTs do if you've never been to PT or you don't know a PT? PT and arthritis in combination, exercise guidelines with arthritis prior to joint replacement, and then PT after joint replacement. So what do we treat? Kind of everything. But as you can see, arthritis is on there. It's a big one. It's one that I see very often, at least 10 patients a day in the clinic. But we do treat everything else. So if you find that you have two things going on, we can do both. So PT and arthritis pain. So essentially through PT, through exercises, through stretching, through kind of a combination of continuous movement, we help to decrease the inflammation and the pain that you're feeling. We improve the flexibility and motion so that going into surgery, you're better off. We learn how to modify your activity if needed, and we also can implement and fit you correctly for any assistive devices if you feel like you need them or if they're in your best interest. We can improve strength and as well as balance. So prior to a joint replacement, we're looking at more low impact exercises. Things like the pool, the bike, those are great because it keeps continuous movement in your joint and it kind of gets that Jiffy Lube, stealing that, back in the joint, and it makes movement less painful. We're looking at 2 to 3 times a week, maybe 30 minutes or so. Also looking at strengthening because the stronger your muscles are, the more supported your joint is. Low weight, high repetitions, and then stretching. Prior to joint replacement, you're letting your pain dictate how much you're doing. So I like to say if it's less than 4 out of 10 on a pain scale, go for it. If it's more than that, maybe back off a little bit. So after joint replacement, and this is kind of based on you individually, but hip replacements, you're looking 1 to 2 times a week post-op for about 6 to 10 weeks. Some patients, depending on your situation, you may get home health. That's kind of up to you and your situation. And then knee replacements, you're looking 1 to 2 times a week for a little bit longer, 10 to 16 weeks. So what do? Lots of stuff. First and foremost, we're controlling swelling and we're regaining your motion. So when PTs are cranking on your knee and you're kind of crying, that's necessary. We're stretching, we're decreasing the scar tissue underneath those scars as they develop, and then we're working on relearning how to walk, relearning how to do all of your functional activities, getting up from a chair. Who feels like they have a hard time getting down into a chair, getting up and down the stairs, in and out of bed, into the shower, anything like that, driving. And then we're working on balance, both on flat ground and on even surfaces. So if you have to walk maybe at a grandkid's graduation on the grass or something like that, 'tis the season, we'll get you there and we'll do it safely. And then, of course, strengthening, so squats, leg press, we use resistance bands, everything like that. And then if you do like to do like pickleball, or if you're a runner, if you like to play tennis, golf, whatever it might be, we can specifically train for those things. So make sure to mention that to your PT. If you want to come see me, you're more than welcome to. But our ultimate goal is staying active, staying strong, and doing the things that you want to be doing. That's our main priority in PT. All right, and then handing it over to Dr. Tomek.
So thank you. My name is Dr. Ivan Tomek. I'm down here at APD, and I'm going to spend a little bit of time and hopefully stay under my 10-minute time limit to talk about hip replacement and technology. So I found this cute little slide. I just had to put that up there because I like that little robot guy. Technology is important, but I just want to back up a little bit, and I think the previous speakers covered this pretty nicely, but why hip replacement in the first place? If you go from the top left and go clockwise around, that's what happens to an arthritic hip joint. You start off with a nice spongy layer of cartilage and a bunch of other material, and eventually it gets soft, it gets shaggy, pieces start flaking off. They don't have anywhere to go, so they stay in your joint. They cause inflammation. Your joint has a ton of nerve endings in it, mostly in the synovium. That cartilage floating around the joint, because there is actually a natural Jiffy Lube in everybody's joints. It's called synovial fluid, a couple of tablespoons in your hip joint. And that cartilage in there creates a lot of havoc. It creates inflammation. Eventually you get to the bottom left picture where you have bone-on-bone arthritis. You have cysts in the bone. You have bone spurs, and that's usually when people end up seeing me. This is an x-ray. We've seen some already, but on the patient's left side, but your right side is a very arthritic joint that I replaced a few days ago. Lots of cysts, narrowing of the space between the ball and the socket, and a lot of bone spurs.
Okay, I'm going to have to do this again. When we do a hip replacement, we essentially remove the arthritic ball at the line that I've drawn there, and we do that with a little electric saw. Orthopedic surgeons have lots of tools. And when we remove that, we then prepare the socket by first reaming it out, removing any of the excess little tiny leftover bits of cartilage that are in there, creating a special slot-shaped opening in the femur to put the implant. And those are the implants that are in there. I have one here at the end. If somebody wants to take a peek at it, I'm happy to hand it around. When it's actually in the joint, it looks like that. Obviously, that's a simplified diagram. All the skin and muscles have been removed, but that's what the joint looks like when it's actually in place. That's the post-operative X-ray. And this is what we look like in the operating room. We all wear these. Truly, orthopedic surgeons get the best toys. We wear these space suits. I think initially the thinking was that this reduced infection. I'm not sure that the studies truly support that anymore. They're protective suits more than anything else. There's some aerosol, and you don't want to get stuff on your skin and in your eyes, and so that's why we wear those. And this is the ultimate goal, right, is to restore somebody to this. And this is Emma, and I cannibalized this from Facebook. So that's what made me say I really have to get her to come to this presentation tonight. So this is the granddad of hip replacement, Sir John Charnley from the Wrightington Hospital in Lancashire, England. And, other people did hip replacement-like things before him, but he's the guy that gets the credit. In the 1960s is when his first forays into hip replacement started. Back then, all the implants were cemented to the bone with dental cement. Some still are today, but that's largely been replaced by titanium surfaces that the bone grows into. That's the X-ray. It was a painful and unpredictable procedure at the time. If you look at line A, that's where the bone was cut, and that's how you got into the hip joint. You cut the top of the femur off. And then there was all kinds of elegant ways to put it back with cables and wires and so forth. And having tried this a couple of times, it's not as easy as it looks. It never looks that nice when you're done. And often the wires break. That piece of trochanter along with the attached muscles goes north, and then the hip sometimes pops out of socket. It is, thank goodness we don't do that anymore. So I'm going to digress here for a second and say that the most important thing that's happened in hip replacement in the last 10 years is not technology. It is probably surgical approaches and materials. I'm not going to talk about materials much, but I am going to talk about surgical approach. All of us at this table who do hip replacement do it with an anterior approach. Now, that's not the only approach you need to know. If, like my colleagues here, you do revision, you also need to get into the joint from the back, because there are cases where you simply won't be able to get in through the very small incision in the front between two muscles. But this approach has really changed joint replacement. I think a lot of the credit for same-day joint replacement surgery goes to this surgical approach. By not cutting the muscles, it hurts less, the recovery's faster, and as a result, people can get back to activities faster. And studies have consistently demonstrated that compared to the older approaches, this one hurts less and returns you to function better. The long-term results are no different. They're the same, but in the short term, this is the least painful way to have a hip replacement. Look, it's still a surgery. I'm not telling you it's not painful, but it hurts less than it used to. This is the table that we use here, the Honda table. They use that at Dartmouth as well. It looks like a medieval torture instrument, but it's a really handy instrument. You put your legs into those ski boots. There's a hook there that can elevate the femur to hold it in view while you prepare everything, and it really, in my view, makes the operation easier. There are people who do it without this table. My hat's off to them. I'm not capable of that, I don't think. This table is like the cornerstone of my surgical instruments. This is technology, and it helps in the operating room. This is where the incision is. It's usually 3.5, 4 inches. If you're a bigger person, you need a bigger incision, so sometimes the incisions are bigger. This is just now a foray into some other technology as it relates to hip replacement. When I was training and when I finished my training in 1999, we were templating like this with an acetate that we laid over the X-ray. We had a little wax marker. We drew little lines on there. And I still remember having to show up at hospital for special surgery. I had to have these all templated, or my resident did, or there was a lot of yelling that happened if that preparation wasn't done ahead of the case. So surgical planning is very, very important to all surgeries, hip replacement included. And this is what happened sort of in the early 2000s. And when I was at Dartmouth, we published on this a fair amount, or presented on it, I should say. This is digital templating, two-dimensional digital templating. And I'm not going to go through this except to say that what you take into account is the patient's leg lengths before surgery, their anatomy. You try out different implants to see what fits. You can get a pretty good idea of the size of implant that you're going to put in. If you have to add length because the patient's femoral head is collapsed or they've lost cartilage, this is the place to do it. You then draw that line, the horizontal line that you see. In this case, that line is drawn on the bottom of what are called the obturator foramina. That's a natural hole that's on the either side of your pelvis. And the relationship between that and the femur tells you if the leg is where you want it to be lengthwise or not. I was just at a conference in Belgium last month where people were now talking about 3D templating, and I don't know that anybody does that yet around here. Maybe they do. I haven't done this. For this, you need a CT scan or an MRI. But this is sort of, this is pushing the boundaries of technology. Does it help? I'm not sure. Is this any better than what we're doing? Does it give you a better result? I'm not sure of that at all, but it's certainly interesting to see where technology takes us. So preoperative planning, look, there's a couple of reasons we do preoperative planning. That x-ray is from Wikipedia, and it's interesting. This is the first x-ray under hip replacement, and it shows a patient with a huge leg length discrepancy. You can see if I draw a line across there, the distance, and look on the left side first, between the lesser trochanter and the line, and on the right side is clearly different. And that's not the goal of surgery. Patients who have leg length discrepancies after surgery are generally not very happy. People don't notice them if they're very small, but if you have a big leg length discrepancy, you walk funny, and sometimes it can actually overstretch the tendons and it can cause pain. So technology and the planning that we do before surgery aims to avoid that. Dislocation is not something you want after hip replacement either. And good planning should be able to avoid this. This is the cause sometimes of positioning the cup and the stem incorrectly and leading to instability. And it is this that has, I think, spawned the interest in robotics, is avoiding some of these complications. Now, I had to put this in there because I was born in the Czech Republic. Robot is a Czech word. It's about 100 years old, and it's from the Czech word robota, which means forced labor. The Czechs have been, conquered over and over by first the Germans and then the Russians, and so forced labor is a part of the culture over there. But it is truly an exaggeration to say that there's robotics in hip replacement right now. There are various degrees of technology, but there is no robot that walks into the room or rolls into the room and does the operation. Your surgeon still does that. It's just that your surgeon now has some better tools to do it. Probably the thing that comes closest to a robot, because it does cutting, it does reaming, it actually puts the component in, is this robot from Stryker. We don't use it here. I've had a chance to demo it. It's very interesting. Again, I'm not sure if it makes the operation better, but this thing actually has an attached reaming tool on that arm over there. You still have to make the incision, put it in the right place. You need a preoperative CT to get a map of the hip so that the robot knows where it's going. But it's a very interesting application that I'm sure took thousands of man-hours to get to this point. What I use is a Smith & Nephew tool, another company. There's like 4 or 5 big implant companies in the world. Medacta is another company that gets used by the folks at this table up here. And this is a preoperative tool that, and it's hard to see, allows you to plug in a bunch of different patient activities if you know what they like to do. For example, if you've got somebody who likes to squat or somebody who does yoga, you can plug some of those activities in there. You can put in your surgical plan, and it will tell you how to position the cup in a way so that the patient does not dislocate their hip during those activities. It's interesting. Does it help the operation? Has it helped my operation? I'm not sure, but it's a really neat application of technology. This is what the quote-unquote robot that I use it looks like. It is a screen, okay? And at the top, that thing that looks like 2 eyes up there, those are 2 sensors that sense infrared light that gets bounced from that machine to little balls that I put in the patient. So I attach 2 of those little balls to the hip on the pelvis. I have other 3 little balls that I put on a wand that allow me to paint the inside of the socket, and the computer generates a 3-dimensional model within itself of the socket. It can tell me what size the socket is. It isn't always right, and if I relied on that robot all of the time, I would make some terrible mistakes in the operating room. And I think that's one of the issues with robotics right now, is you constantly have to test the validity of what the robot is telling you against what you're seeing with your own eyes. That's why this is far from being perfect at the moment. At that point, when I put the socket in, it tells me exactly what angle in 3 dimensions that implant is going in at. And it's helpful, but again, it's not always correct. So the future, and this is my last slide, The future is probably some mix of robotics, of navigation, and of virtual reality. I've never used it, but I think Medacta has this for the shoulder, if I'm not mistaken, where you actually have goggles that project an image on the inside. And when you're putting in, for example, the socket in a shoulder replacement, like the bullseye when Luke Skywalker was dropping that bomb in the Death Star, it lines up and tells you how to put your hand to perfectly position that socket piece. So this is where I think the future is. I think we've got a long way to go before robots actually take over the surgery, but they're valuable tools. They're interesting. We're all using them because we think we need to keep up to date with these things, but ultimately it's going to be one of these people at the table or another orthopedic surgeon that does most of the work. Thanks.
I'm Alex Orm. I'm one of the arthroplasty surgeons over at Dartmouth Hitchcock, and I'm going to speak today a little bit about knee replacement and how we incorporate some of the new technologies that are both here today as well as on the horizon for us. So a little synopsis. I'm going to talk a little bit about who knee replacements are for. What exactly is a knee replacement? There's usually some confusion when people come in to talk to us about what exactly it is that they're signing up for or here to talk about, and then a little bit about some of the newer technologies in knee replacement surgery. So just as you've heard about arthritis as an overview, as well as arthritis in the hip, arthritis in the knee is the exact same disease. It is breakdown of the articular cartilage of the knee joint. So on the far right side there or on the far left side that is a normal knee X-ray. So you see a nice wide joint space in there between the femur on the top and the tibia on the bottom. There's plenty of room for the articular cartilage there in the knee joint. That middle picture there depicts a normal knee. You see the nice shiny white cartilage in the middle. There's normal meniscus in the middle there sitting on top of the tibia. Those meniscus are nice rubbery. Meniscus is similar to the cartilage in the end of your nose or sitting in your ear joint, or in your ear joint. Boy, it's been a long day in clinic. I get on an autopilot feature in my speech here. I'm going to start adding punctuation to my dictations here. And then on the far right here, you see where that cartilage breaks down, you start seeing all the knobbiness of the bone. Those are bone spurs or osteophytes, and break down to the cartilage there. You start seeing bone underneath the cartilage. The meniscus breaks down. Instead of being a nice stable C cup, it starts flattening out and fibrillating, and it no longer provides stability and support. And basically what that joint is doing is it's starting to flatten out, and it's starting to try and spread contact stress over a bigger area. Joints that become arthritic start to lose motion. So knees that are becoming arthritic typically don't get all the way out straight, and they don't bend as much. And so frequently people that are starting to experience more severe knee arthritis will start losing range of motion. It'll become difficult to bend their knee fully, and they'll usually lose some of the extension as well, okay? Down at the bottom there is it's behind Dr. Schilling, but OrthoInfo is part of the American Academy of Orthopaedic Surgery. I'd encourage you, it's a good website that has a lot of information that's aimed at patients who are looking for information about arthritis and joint replacements. And so orthoinfo.com is a good website with some other information if you're interested. Joint replacements are for people with severe knee replacements are for people with severe knee osteoarthritis, okay? A good candidate for a knee replacement surgery is somebody who's been dealing with pain and loss of function for several months or longer, okay? If you've had knee pain for 3 weeks, you're probably not ready for a knee replacement. But if that pain has been going on for 3 months, 6 months, 9 months, or years, and it hasn't been getting better despite efforts at physical therapy, or you've been avoiding things that hurt, or you've been taking Tylenol, or rubbing Voltaren gel on your knees, or using Advil and Aleve, or you've gotten prescriptions from your doctor for Celebrex, or Meloxicam, or Naproxen, those are the non-surgical treatments that are typically most effective for long-term management of arthritic knee pain. I would add at this point that narcotic medications are not effective treatments long-term for osteoarthritis pain. So it's not a medication that we typically prescribe, and it's not usually helpful for arthritis, okay? But when you have knees like this gentleman here in the middle there, where you see bone-on-bone severe joint collapse, if you compare that to that normal knee X-ray I showed on the previous slide, when this patient's been dealing with pain and loss of function for months or years, then they're a good candidate for a knee replacement. Some people are better candidates than others. If you come in and you suffer with morbid obesity and you have a BMI of 60, which means that your height and weight ratio, and you carry a lot of extra weight, that can increase your risk of some complications with knee replacement, and it can make the surgery a lot riskier, okay? If you have some medical conditions like rheumatoid arthritis, or let's say you've had a kidney transplant, or maybe your kidneys just don't work as well as they used to, and your primary care doctor has been worried about them, that can increase your risk of some of the complications of joint replacement surgery. It doesn't mean you can't have a joint replacement, but it means we have to weigh some of the benefits of the surgery with what some of the risks of that operation could be, like infections and things like that. And we don't want you to have a problem with the surgery. We want you to be as healthy with this. We want you to be as healthy when you have the surgery, and we also want you to be as happy after the surgery as possible. And so when you have these when you have arthritis like this, when you have bone-on-bone arthritis and you've had pain for months or years, then you can go on and you can have your knees replaced. And that's what a knee replacement looks like in the x-rays afterwards, okay? Knee replacements, as opposed to what Dr. Tomek talked about with a hip replacement, where the hip is actually replaced. You actually remove the old femoral head and you replace it with a new ball and socket. A knee replacement is more aptly described as a knee resurfacing, okay? We trim the end of the femur. We remove about a 5 to 6 millimeters of cartilage from the surface at the end of the femur bone, and we remove about 8 to 9 millimeters of cartilage from the top of the tibia bone, which is the bottom bone in the knee. And then we apply a metal cap on the end of the femur and a cap on the top part of the tibia bone, and there's a plastic shim that goes in between them. So the reason why those metal parts, the white parts in the knee, aren't touching is there's a plastic bit in between them that doesn't show up on the x-ray, okay? And that's what the knee replacement actually is. So you go from knees in the middle there, where you're bone-on-bone arthritis in the middle of the joint, and then after the surgery, that knee is replaced, and you can see how that leg, that gentleman was walking around. I like to tell folks they could walk over a fire hydrant and not even realize it. And then after the surgery, you can see the legs have been straightened out and that deformity has been corrected somewhat, okay? And so that's what a knee replacement looks like. This is a little bit more of the detail about how the surgery is done. And this is one of the technologies that we use in knee replacement now, okay? So this is one of the technologies that I use in knee replacement. This is actually, this is a CT scan that's used to generate the surgical planning for a knee replacement. This plan and this model don't go one-to-one. This is something that I happen to have on my shelf. But this is a 3D generated, 3D printed, a CT generated 3D printed model of a patient's knee from before they had their knee replaced. And using that, you can generate these cutting guides that actually lock onto the bone to this patient's specific anatomy. And you can use this to execute the surgical plan that you have. You don't have to do it this way. This is a simple way to do it, especially at a smaller hospital like APD or New London, where they may not have as much equipment available. This is a nice way to cut down on the amount of stuff that you have to bring into the operating room to do the surgery, and it can make the surgery a little bit easier on the team. It doesn't make the outcome of the surgery any better or any worse, but it just makes it a little bit more straightforward for the team that's there. If you look on the far side there, you can see before the surgery, that's the limb alignment from before the operation. So this patient's a little bow-legged, like those x-rays we saw beforehand. After the surgery, you can see that that bow has been corrected a little bit. Okay, so the limb is a bit straighter. That's the patient's normal anatomic alignment. And you can see the yellow and the green in that second image. That's the femoral component and the tibial component that are now in that new limb alignment. And if you look at these bigger versions here, so in the middle, that's the knee before any of the cuts are made. So all the lumps and bumps there, that represents the arthritis. That's how you can see the arthritis on this CT scan. And so that's the front of the knee, and then that's the back of the knee. In between, in that middle view there, you can see now we've actually cut the bone. So we've made the 5 cuts around the top of the femur and the 1 cut across the tibia. So you've gone from that craggy, crevicey appearance of the femur and the tibia, and now you've got these nice uniform flat cuts that go all the way around the femur and across the top of the tibia. And then here is where we've put the implants into position. So there's the femoral component, and that's the tibial component. That tibial component has a keel that sits down into the bone below, and that helps anchor it. And then that plastic piece is what's going in between in this space right in there, okay? So like I said, this is like a cap sitting on the end of the femur on the top of the tibia. It's not an in-block replacement the way a hip replacement does that, okay? Knee replacements come in some varieties, okay? So not every knee replacement looks exactly the same. So in the middle there, so this patient had partial knee replacement. So that's another option for people that may have more limited osteoarthritis of the knee. So if the arthritis in your knee is just on the inside of your knee, or just in the front of your knee, or just on the outside of your knee, you may be a candidate for what's called a partial knee replacement. So that patient there had partial medial knee replacements, okay? That can be an option in some patients. This is just an example here that not every knee replacement looks the same on the x-ray. So depending on the manufacturer and the disease that you have, the style of arthritis that you have, you may need a slightly bigger implant. And some of those implants are designed to resist different forces and different stresses. And so not every knee replacement has to be done exactly the same for every patient. And even you can see there, that's one patient with 2 different types of knee replacements. So it doesn't have to match on the x-ray necessarily. Some surgeons like them to match, because if one patient really likes their knee replacement and then they come back and you did it differently and they wonder why does that knee look different than I love this knee, why did you do it differently? And this is how I do my knee replacements. I think this one works really well. So luckily this patient's very happy with both of their knees, but it's just to point out that knee replacements can come in a lot of different flavors, okay? It brings me to a little bit more of the technology. Just like with the technology in robotics, if you take anything from this meeting here, this seminar, a good surgeon using a robot can give you a really good surgery. A good surgeon working without a robot can still give you a really good surgery. A bad surgeon using a really good robot will give you a bad surgery, okay? The quality of the surgery that you get is not from the technology that the surgeon uses. The quality of the surgery that you get is purely from the surgical skill of the surgeon and the team that they're working with, okay? A robot is a tool that the surgeon uses to do their surgery, and the outcome of your surgery is much more dependent on the skill of the surgeon and their team than it is whatever technology that they use to execute the surgery, the surgical plan, okay? At Dartmouth, we use a few different surgical robotic platforms or technology-aided platforms. So the robotic-assisted surgery platforms that we use, we have what's called a DePuy Velis robotic-assisted surgery. I'll show you a picture of what that looks like. And then we also have what's called the Smith & Nephew Corey robotic platform. We're technically supposed to call these robotic-assisted surgical platforms because they're not, like Dr. Tomek said, it's not a robot that walks into the operating room and does your surgery for you. It's a tool that uses computer technology to assist the surgeon in executing the surgical plan. And then the Medacta technology platform focuses more on patient-specific instrumentation and what they call augmented reality, which as Dr. Tomek alluded to, essentially helps project an image of the joint on either a screen or on a goggle that you can wear during the operation to help the surgeon kind of see what the trajectory of a screw or the position of the implant is going to be as the surgery is being done. Ultimately, most of the data that is coming from the computer systems is showing you implant size, implant position, and to some degree what the soft tissue tension is of various ligaments around the knee in order to see what your range of motion and various tissue balancing is going to end up with. So these are some of the robotic platforms. So that is the Velis. On the far side there, that's the DePuy Velis robotic-assisted surgical platform. It consists of 2 towers that are in the operating room with you, okay? So on the far side is the eyeball. So at the top part of that is a radar array, and that is actually watching you do the surgery. In the patient, there are 2 radar receivers that are anchored in the bone and are registered at the beginning of the case. So robotic cases add about 15 to 20 minutes of surgical time to the cases. So a robotic case typically lasts a bit longer than a non-robotic case. So your surgical time is usually a little bit longer. Most of us, as we practice and we do more of these robotic cases, our goal is to get our times to where they're essentially neutral to when we can do a robotic case and a non-robotic case the same. But in general, when you look at the data on robotic cases, they typically last about 15 to 20 minutes longer. The other array there is the saw. So you can see it sitting right there in the middle. And it's the there is a radar array on the saw, and it registers and it gets information from that eyeball sitting up there. And as you move the knee around, the saw moves with the knee. It lines up the cuts, and this is the surgical plan that you generate. And so that shows you the position of the bone and the position of the implant on the bone, and then the saw actually executes the cuts for you as you use it. You don't need to put the normal cutting jigs and instrumentation onto the knee that you might otherwise have to use. So it's a way to both plan and execute the surgery that you want to do without some of the traditional cutting jigs that we might use for a knee replacement. But that's what the DePuy Velis looks like. The Smith & Nephew Corey looks very different, right? So there's just the single stand there, and then there's just a handheld burr. And that burr has the same, those blue dots at the top are the eyeballs that are getting information from the eye in the sky there. And the handheld burr is getting information, and it's basically helping you remove the bone that you want to remove according to the surgical plan that you've input into the computer. And so the Corey is not even a robotic arm. It's simply a hand tool that's getting information from the robot, and it's helping you execute your surgical plan according to the data that you put in and what you want your knee to look and feel like after the surgery. Okay, so those are some of the various robotic platforms there. This is the Medacta patient-specific instrumentation. So this is the typical surgical plan. You get a CT scan of your knee prior to the surgery, and it gives you your limb alignment as well as the anticipated surgical cuts that you make during the surgery in order to execute the plan and provide the knee replacement to the patient. Okay, so this plan is what generates these cutting blocks and allows you to do the surgery for the patient. Again, this is not a better or worse way to do the surgery, but it is a tool that a surgeon can use to be consistent and allow for patients to have a very functional knee replacement after they're done. I'll leave it to I'll hand it back over to Dr. Machete.
Perfect. All right, that was awesome, and we're actually right on time, despite your texting me that we're a lot behind. So we wanted to try to get all those. It's a lot of information we just provided. That's pretty much like the whole first year of residency in an hour. Not so much. So I think the general gist is for most of this technology, and we're going to open this up for questions, is that clearly you want a good outcome after your joint replacement. We'll have Emma up here for questions. And seeing a high volume surgeon at a high volume center is probably the biggest driving factor of how your outcome will be. And so we're all up here because we're high volume surgeons at high volume centers. And when you're looking for a surgeon, you really want to know how many hip replacements, knee replacements, hip revisions, knee revisions, partial knee replacements, whatever it is, how many they actually do. Because if someone's doing 1 or 2 a month, that's probably not enough to really be competent. And this technology can help us all maybe do it a little bit better, but truthfully, with or without the technology, your surgeon should be able to do your joint replacement. This is a bit of a selfless plug for Rob Taylor, is a patient of mine who wrote this book. He was an author and told me he was going to write a book on the patient journey through hip replacement. I thought he was a little bit crazy. I was going to invite him actually, but Emma was. Is he in the back? No. Just yeah. No, he's actually a great guy, and so he just actually had his other hip replaced, but he wrote this book about his journey through hip replacement, which is it's an easy read if anyone's interested and wants to get a sense of what it's like from a patient perspective, because commonly we can tell you what it's going to be like and what we think it's going to be like, but every one of your journeys is a little bit different.